Cook released the 4.6 10-shooter Said multiband ligator in 1996. Its reliability and superior band retention has made the 4.6 10-shooter the gold standard for band ligation. Band retention is a potential clinical concern in relation to the risk for rebleeding. That's why the Said multiband ligator uses bands that demonstrate lower slippage rates when compared to other bands on the market. Since the original release of the 4.6 10-shooter in 1996, Cook has made significant enhancements to this already superior ligation device. The most recent enhancement is the addition of the universal OptiView recessed band design barrel. This design simplifies ordering by securely fitting on a wide range of scopes with an 8.6 mm to 11.3 mm outer diameter, in addition to facilitating full view of each procedural move. The universal barrels are available with 4, 6, or 10 bands, as well as Fujinon versions. This video will showcase Cook Medical's universal 4.6 10-shooter Said multiband ligator and will review the simplistic setup, functionality, and clinical use. Use of an endoscope in a sound state of repair is a prerequisite for a successful multiband ligation procedure. It is vital that the integrity of the working channel is intact, as grooves or other obstructions in the channel can potentially cause the device string to catch, resulting in band deployment difficulty. The component parts are the barrel with preloaded bands and attached trigger cord, multiband ligator handle, loading catheter, irrigation adapter. Examine the features of the handle. It has 2 positions which control rotation. The firing position allows the handle to be rotated in the forward direction only. Two-way position allows the handle to rotate in both directions. Prior to introducing the endoscope, keep the handle in the two-way position. Insert the handle into the endoscope accessory channel following these instructions. For Olympus, with rubber cap on the accessory channel, lift the plug on the cap and insert the stem of the handle. For Pentax, remove the rubber cap from the accessory channel. Place the stem of the handle through the cap. Then replace the cap with inserted handle as one unit into the luer lock fitting of the accessory channel. For Fujinon, place the stem of the handle through the rubber cap attached to the endoscope accessory channel. Note, the irrigation adapter may be used to puncture the white self-sealing valve prior to introducing the loading catheter. Introduce the loading catheter through the white seal in the handle and advance in short increments until it exits the tip of the scope. Note, the loading catheter is identical on both ends and may be introduced either way. Attach the trigger cord to hook on the end of the loading catheter, leaving approximately 2 centimeters of trigger cord between the knot and the hook. Withdraw the loading catheter and trigger cord up through the endoscope and out through the handle. Dispose of the loading catheter per institutional guidelines for biohazardous medical waste. Attach the barrel to tip of the endoscope, ensuring that the barrel is advanced onto the tip as far as possible. Note, when placing the barrel onto the distal end of the endoscope, ensure that the trigger cord does not become pinched between the barrel and the endoscope. With the endoscope tip straight, place the trigger cord into the slot on the spool of the handle and pull down until the knot is seated. Note, the knot must be seated into the hole or the handle will not function properly. With the handle in the two-way position, slowly rotate the handle clockwise to wind the trigger cord onto the handle spool until it is taut. Note, care must be taken to avoid deploying a band while winding the trigger cord. Check the endoscopic view. To maximize visualization, position of the trigger cord may be altered by rotating the barrel. Note, Endoscopic view broadens as each band is deployed. Lubricate the endoscope and exterior portion of the barrel. Caution: do not place lubricant inside the barrel, and do not apply alcohol to the device. The device is now ready for ligation of esophageal varices or internal hemorrhoids. The most common indication for endoscopic band ligation is for the prevention and treatment of esophageal variceal bleeding. Esophageal variceal bleeding is a major source of morbidity and mortality in patients with portal hypertension from various causes, including end-stage liver disease and cirrhosis. Nearly 90% of patients with cirrhosis will develop esophageal varices sometime in their lifetime, of which 30% will bleed. Once developed, varices will usually increase from small to large. An endoscopic variceal banding device was initially introduced in 1986. Endoscopic band ligation is now established as standard therapy for the management of bleeding esophageal varices. There is now a substantial body of data that suggests that endoscopic band ligation is safe and effective treatment for both acute esophageal variceal bleeding and the prevention of bleeding. Multiple randomized controlled trials of therapy for acute esophageal variceal bleeding showed endoscopic band ligation to be superior to endoscopic sclerotherapy. With the handle in the two-way position, introduce the endoscope into the esophagus. After intubation, place the handle in the firing position. Visualize selected varix and aspirate into the barrel. Caution: prior to band deployment, ensure that the endoscopist's hand is positioned on the handle of the device rather than endoscope controls. Maintain suction and deploy band by rotating the handle clockwise until band release is felt, indicating deployment. Note: if band will not deploy, place handle in the two-way position and loosen the trigger cord slightly. Place the handle in the firing position and continue with the procedure. Release the suction button of the endoscope. Insufflate air, then withdraw the scope slightly to release the ligated varix. Note: an irrigation adapter is provided with each device. If irrigation of the accessory channel is desired to clear the viewing field, attach the adapter to a syringe filled with sterile water and insert into the white seal of the handle. Irrigate as necessary. Repeat the ligation process as needed. Note: more than one ligation band for each varix may be required to control acute bleeding. If more bands are required, remove the endoscope and attach a new device. An average of 3 to 4 ligation sessions may be required to obliterate varices. Upon completion of the ligation procedure, remove the endoscope from the patient and dismantle the device as follows. If all of the bands have been fired, remove the handle and attach trigger cord from the accessory channel. Remove the barrel from the endoscope tip. If any unfired bands remain on the barrel, place the handle in the two-way position. Loosen the trigger cord from the spool, then remove the handle from the accessory channel cap. Detach the trigger cord from the handle slot, and remove the barrel from the endoscope tip. Then pull the trigger cord through the channel and out the endoscope tip. Upon completion of the procedure, dispose of the device per institutional guidelines for biohazardous medical waste.